Good evening, everyone. It's my understanding that this space is sometimes used by people who are working their way out of certain dependencies, different kinds of 12-step programs. And so I feel like I should stand in front of you and say, good evening, my name is Church Hines, and I have passion about compassion. Because I know we all have that same problem here. This is, I think, probably a gathering of compulsive carers anonymous. Seriously, though, it's always a pleasure on behalf of the Visiting Nurse Association to welcome you to yet another special evening brought to you by our Madison Dean Initiative. The Madison Dean Initiative truly sets end-of-life care at our agency apart from others. It enriches everything that we do. We like to think that we do things by the book, and oftentimes Madison Dean has written the book. And it is a wonderful relationship that ties together the people who actually do the laying on of hands and the caregiving, and those who do the strategic thinking and the pondering and constantly keeping us on the cutting edge. Year after year, we have brought some of the most distinguished voices from around our America and in some cases from across the seas to talk to you at evenings such as this. This evening we're sticking a little closer to home. A little change in venue, a little change in approach, but certainly no change in enthusiasm and certainly no change in the number of people who are coming through the door. So to kick things off officially, it's my great pleasure to introduce the current chair in a long, long line of wonderfully talented and committed chairs of the Madison Dean Council. It's my pleasure to introduce Judy Leaf.
Thank you, Church, and thank all of you for coming out in this beautiful evening to look into a topic that affects every one of us, which is how we want to live the last parts of our life, how we can live fully, and how we can help one another going through the challenges and the confusions and the intensity of a serious illness and relating to the end period of our lives, and how we can work with chronic illness, and which more and more as our population ages, more and more people have not one, but not two, not three, but many chronic illnesses that we navigate for many years. So there couldn't be a more relevant topic than the topic of how to navigate serious illness, which all of us will face one day or another. My name is Judy Leaf, and I'm the current chair of the Madison Dean Initiative. And for many, many years now, we've been doing various educational events and bringing speakers to help inform both the community at large and the medical community on issues around end of life. Our mission is to change the face of dying, to take control, to give people the power to navigate the system to their own benefit, and to demand and bring into being the services and support that we all need and that are not always currently there. Our belief is that knowledge is empowering, and that's why we're calling our series Knowledge is Power. We want all the members of Vermont, all the citizens of Vermont, to be empowered to know what the options are, to know what the rights are, to know what services are available. We're very concerned that sometimes the suffering that people go through could be alleviated with greater knowledge and with greater advocacy. We think that you should be able to advocate for your own needs in healthcare and advocate for those that you care about and that you love. So this initiative started in a very heartfelt way with two well-known Vermont physicians, James Madison and Robert Dean, who both were very much concerned with this and concerned enough to be the spark that set a series of activities in motion that made these kind of events possible. And so we're very honored that we still have the founding mothers, we call the founding mothers of our initiative, Joan Madison and Estelle Dean, through their great conviction and knowledge and support and passion for improving people's lives. We owe them a great deal of gratitude and respect. Please, please stand so we can. Not only do we have Joan and Estelle, but we also have Joan's wonderful apples that are renowned throughout the region. And so please help yourself to apples. Take them back as a souvenir of your time together here. It's a real treat every year to get the fresh apples from the Madison orchard. So without further ado, I know we want to get right on to the main event. We're very honored to have Dr. Zale Berry and Ursula McVeigh as our presenters tonight. And from our perspective, these are world-renowned people, but they just happen to live here. And we're so fortunate that they do live here, and they are dedicating their lives to this cause of better care for people facing serious illness. Dr. Zale Berry is a medical director of PACE Vermont, which is a nonprofit program for all-inclusive care for the elderly. It provides people with alternative to life in a nursing home. She's a founding medical director of the Fletcher Allen Palliative Care Program and has many years of experience in private practice working with seriously and terminally ill persons. In 2007, she was, voted or deemed a Vermont Healthcare Associate Professor of the Year. So famous and popular. When I had a dear friend, we were guardians of a beat poet for many years called Peter Orlovsky, and in his final days, Dr. Berry was so helpful with just a few simple words of advice, and a few little shifts in care made all the difference in his final days, so I have not forgotten that. Our other speaker is Dr. Ursula McVeigh, and she's palliative care doc at Fletcher Allen Hospital and medical director of hospice of the Champlain Valley. Both of these doctors are active in end-of-life issues and in promoting the kind of policies and the kind of medical procedures that will make an approach to this period of life not just a medical event, but support for the human dimension, the human dimensions on this psychological, spiritual, social, family. It's a complex thing. We're people, we're not patients, and we may be old, but we're still alive, and we need support, and we can support one another. So we're very honored and eager to hear what you'll have to say that can help people navigate this important part of life.
Well, we are really humbled by the showing tonight after work. For many of us to come out and talk about palliative care is really inspiring. I think it's a testament to the community of Vermont. And navigation is the main theme of what we're going to be talking about. And also, palliative care is in some ways being a medical translator and looking at helping people formulate what their values and goals are, and us translating that into a medical plan that best suits those values and goals. Starting with a brief overview about what palliative care is, the definition being it's an interdisciplinary specialty, and the aims of which are to alleviate suffering, to improve the quality of life for patients with advanced illness, and to support their families. And it can be provided simultaneously with other appropriate medical treatments. Balfour Mont was the founder of the modern palliative care movement, and he had visited Cicely Saunders Hospice in England and said, the philosophy of hospice care is wonderful care for people in the final phase of life, and it should be applied earlier. He was a surgeon up in McGill. And he said, whole patient care requires a whole person. Until one comes along, use your team. And I want to pay homage that we are two physicians who practice palliative care. But there are many disciplines that participate in palliative care. And if you look at the hospice program, you have chaplains and social workers, nurses/case managers, and a very active volunteer program, and pharmacists. And so it takes multiple dimensions of professionals to provide care to the whole person. And what palliative care is its attention to physical symptoms, alleviation of physical suffering, pain or shortness of breath and nausea. And from the nursing and physician perspective, that we consider ourselves symptomologists, that we are experts in symptom management. And in traditional medicine, if you were to present with your doctor with shortness of breath, they would take a history with the intent of figuring out why are you short of breath, and then they would treat the underlying disease, like you have a pneumonia and you need antibiotics. There are some illnesses where, despite best medical management, people still have symptoms, and we need to treat the symptoms aggressively. And that's treating shortness of breath in people that are on optimal medical management. And that's the specialty of palliative care, especially the role of the physicians and the nurses. We also help with medical decision making, and this is that piece of being medical translators. And this is the amount of technology and medical decisions that are involved in our healthcare, especially in the final phase of life, is astounding. And we help people navigate that out in the community and in the hospital. Psychosocial spiritual support. I think of the chaplains as being the philosophers on the hospice team and on the palliative care team, where they talk about the identity that one faces and the challenges to one's identity as they face a serious illness, or as they grapple with mortality and may have religious or spiritual issues about the meaning of their illness or what happens after somebody dies. And we look at, for palliative care, being about the focus being quality of life. And before I did palliative care, I was a hospitalist, and it's really a different lens that when I walk into a room that I'm looking at somebody with, and it's really getting tuned into what's most important to this person and how can we help them achieve it. And that's where the focus is about living, and living well as we face serious illnesses. And when is palliative care appropriate? Early stage serious illness, especially if there are a large volume of troubling symptoms. Later stage serious illnesses and transitions, times of transition of goals, where the goal may go from being hopes of getting stronger to hopes of being at home to hopes of being pain-free. So we help with transitions of goals. And it's also important in patients with chronic illness who have needs for specialized care. When we look at what do people want in their final phase of life, that think of all of the stages of life, like infancy and being a toddler and young adolescence, that at each stage people have milestones, things they want to achieve, things that are important to them. And when you ask patients what's important to them at the end of life, what they describe as they want to be comfortable and pain-free, that people want to feel like they have a sense of control, they want to be contributing to their family and to society, they don't want their family to be burdened by their illness, and they want to have strengthening relationships of their loved ones. And people also want to avoid inappropriate prolongation of a dying process, and people want to avoid undergoing burden, especially as they near the end of their life, and especially if that burdensome treatment isn't going to get them where they want to go. So we're going to illustrate with 3 cases that both Zale and I have participated in the care of.
This trade-off back and forth we hope will be fairly smooth. We'll start with the case of Mrs. G, her theme was, I want to keep fighting this cancer. She was a 68-year-old woman who had ovarian cancer for a number of years and had been receiving successive chemotherapies, meaning she would have one type of chemotherapy until the tumor was growing despite it, and then she would switch to a different kind of chemotherapy and go till that was no longer helping her, and then she would go to another. And she was very frustrated because the current chemotherapy she was on, she just wasn't bouncing back. She had done a couple of cycles and she had persistent nausea, whereas typically chemotherapy that causes nausea, it's a shorter lived thing. This was really hanging on. She was really fatigued. She wasn't sleeping well. And she knew me from a different life of hers, and she said, maybe Zale can help. And so she called me. And interestingly, her oncologist didn't see me as somebody who could help with these things. The oncologist saw me as a person you called when somebody was going to die. And he was trying to convince her, this is not what she said, no, I think I really do need this help. Because she couldn't have another cycle of chemo till she could get some weight back on and eat again and get some decent rest and really feel well enough to do another cycle of chemo. So she called me and I went to see her and we got her nausea under control. I really felt that the sleep problem was probably a sign of some depression. We treated the depression. Her appetite came back, her sleep improved, she gained the weight she needed to, and she went right back on her chemotherapy. And she did very, very well again for a while. She was somebody who was very clear about her goals. And she was fortunate to really know that there was really more that could be done. You know, the oncologist saying, well, come back when you feel better and I'll give you more chemo, didn't really help her too well. And that's one thing that, unfortunately, you might have to push for. There are some oncologists who really, you know, could give this talk as well as Ursula and I could give it and really get all this. But there are a lot of oncologists who don't. And they really see palliative care as only for folks at the end of life. And yet here's a place where palliative care early, not early in the sense of at the beginning of her disease, but certainly in the very, very active stage of treatment of her disease, palliative care made a big difference. She had a very active life. She wanted to continue it as long as she possibly could. She was very well versed about what chemotherapy could and couldn't do for her at this point, and she continued to have a very active life. And she went through about 1.5 years more of chemotherapy, and then I believe I said goodbye to her when she left for Arizona for the winter. Help me, you're the one who knows how to do this. Oh, it's over here. Okay, good. 18 months later, I got a call. She was in Arizona. She said, you know, I'm really not feeling very good, and I think I better get back to Vermont. And I said, okay. And she got off the plane, and I saw her at home, and she was really sick. And so I said, we're going to go straight to the emergency room. And that's where she went. She was having fatigue, she was having recurrent fevers, and she was just very, what we call the eyeball test. You know, when you look at somebody and you go, oh no. And so she went to the emergency room. And the years of chemotherapy she had, being very damaging to the body, because that's what chemotherapy does, had actually resulted in her a new diagnosis of acute leukemia. So she now had a tumor of white cells in her blood. And interestingly, no sign of recurrence of her ovarian cancer, which was stable. And this was pretty devastating news for somebody who literally 3 months before, maybe 4 months before, had a trip to the White House, and she took her grandson to the White House. So, you know, she'd really been living a really active life, and so this was pretty devastating. I went to see her, and I was kind of afraid of how she was going to feel about this, because she'd been so strong about, you know, I'm going to fight, and yet I knew that acute leukemia in this kind of a setting, that the aggressive medical care focused on trying to treat her leukemia would be a very difficult thing for somebody whose body was already had the ardors of years of chemotherapy. It would be a very tough thing. And I went thinking that we would be having a discussion about what her alternatives were, and instead she said, no, I know this is a sign that I'm done, and I just want to be comfortable. So frankly, I didn't do a lot of work with this lady. She kind of did most of the work herself. But a lot of times in palliative care, we're really helping people at this kind of a fork in the road say, you know, here's your options, and here's where these paths, we're going to talk about paths again, but you know, there are a couple different paths you could choose to go down. And especially in this situation, both paths available to her probably went to the same place, which meant that this was her final illness and she probably would not survive. And so it really was about what kind of view she wanted on the path. And she was very clear about what she wanted. So in her situation, we started out with, you know, disease, earlier in her disease, along with active treatment, palliative care was really all about symptom management and keeping her, what am I doing? I'm doing this? Thank you. How does Oprah do it? So Anyway, palliative care at early stage was really about symptom management. But there was something else that happened that wasn't necessarily conscious, which was that when one has, I'm sure some of you will resonate with this, but sometimes when a patient's doctor is treating a disease, one feels pretty strongly that doctor is pretty invested in the disease, and really what we want to do as doctors is invest in our patients, and so that people know that our commitment is to them as a person as opposed to their disease. And what this Mrs. G learned was that there was a system and a group of people out there that would help her no matter what happened down the road. And I think that's a really important thing that palliative care does for folks, is it really becomes sort of a safety net that no matter what is going to happen with the disease, palliative care is there to help you feel better. It doesn't matter what stage of disease you are in. It doesn't matter whether you are dying or not. Palliative care is there for people to, you don't have to qualify necessarily like you might have to qualify, say, for hospice, which is a subset of palliative care. But I think that was an important thing. And then when we then transitioned later on in her illness, where she had a whole different set of circumstances, palliative care then was about helping her understand what her options were, what the pros and cons of those might be relative to what was important to her, and then helping her choose what would really give her the life that she wanted to lead for the last part of her life. So we're going to transition now to a different case.
So Mr. A is a gentleman that I met working at Fletcher Allen Hospital, and he had advanced heart failure. And the symptoms that he had from that was that his heart was failing and his body was retaining a lot of fluid that would build up in his legs and would build up in his lungs. And he would get admitted at the point when he was having trouble breathing and would get medical management to help remove the fluid from his body. And he was becoming, over the course of the year, weaker and more debilitated. And he had a lovely wife, and they were childhood sweethearts. And he used to ride a motorcycle, and he seemed like he had a lot of tough stuff in him. And they were very tightly bonded. And I took care of him for a number of times, and the number of days that he would stay out of the hospital was getting shorter and shorter. And the difficulty in keeping the fluid off was getting harder. And he was getting weaker. And his wife was getting very, very scared and very stressed. And he was committed to be at home. He wouldn't consider, even after a stay in the hospital, going to a rehab facility for a short period of time. He just wanted to be at home, and she was going to do anything she could to help achieve that, despite the effect that it was having on her own health. And his primary care doctor was also her primary care doctor, and so he knew that this was a very stressful situation. And the last time that he came into the hospital, and he had even worsening trouble with his fluid that now it was building up in his stomach. And he just said, my body is just really quitting on me, but from here up, I'm all get up and go. Here down, have it. And he just felt like he wasn't getting the same returns from coming into the hospital. That he wasn't coming out stronger, he was coming out weaker. And they were getting very scared about where this road was going. And they were also very scared to talk about it with each other. And it was the type of situation that I would be in the room and we would be talking about very optimistic things, and his wife would follow me out of the room and just say, I really have to talk about this because I'm really scared. And I think he's scared to talk about it, but I'm worried that he's nearing the end of his life. And I want to be able to take care of him at home, and I will do anything to care for him at home. That last hospitalization in our medical workup, we found out that his heart function had significantly declined over the last few months. It was really at a critical level. And so we had a sit-down meeting, and part of what we call a goals of care discussion is talking about prognosis and illness and helping people picture what their future looks like, and then helping people decide how they want to be spending their time and what's important. I want to say that part of that discussion is delivering bad news, because part of that is saying that his goal or his hopes of getting stronger are not achievable. And part of that discussion is talking about that he's in the final phase of his life. And at some point, his life is going to end from this illness. And that's the bad news that people grieve. And then the hope in that is giving people control over what do you want to do between now and then. That's going to happen. We'll have a plan for the end, but we're going to focus on what's important to you now. And when time is getting short, time becomes very precious, and how people spend their time becomes very precious. And so we talked about what's important to you, and he said that I want to be at home. I don't want to be a burden on my wife. And he wanted to live as long as possible, and he wanted to be as comfortable as possible. And so we sat down and we talked about hospice care. And he was familiar with hospice as being care for patients who are at the very end of life. And we talked about what hospice care means for somebody with heart failure. And that hospice care means living as well as you can for as long as you can, with a plan of, for when you're at the end of your life, helping you die peacefully. And so we're talking about the plan for living as well as you can for as long as you can, and that's going to be very attentive disease management. What a lot of people don't know is that hospice care for heart failure patients, when they compare groups of patients, that patients with heart failure live longer when they're enrolled in hospice. It's a very good home care program that does such wonderful care of patients, but seeing somebody in their home and seeing how they're doing, titrating meds to help somebody be as functional as possible and as comfortable as possible is important for living longer. And what he was giving up to be in hospice was a plan of care so that there was an emergency plan so he wouldn't have to go to the ER if he got into trouble. He wouldn't have to be admitted to the hospital, that they could manage anything that happened at home, whether that was an exacerbation of his heart failure or whether that was that when he was at the end of his life. The other intervention was connecting him with Dr. Berry to be his physician, and at that time, well, and she still does, but a very active home care, palliative care program. One of the other detriments he had was that he would start having symptoms of heart failure but couldn't connect with his doctor and have his medicines adjusted in an expedited manner. And so it was part of a bad news discussion, but there was a lot of hope in it. And for his wife, it was just a sigh of relief, because aside from his disease management and aside for a plan for how we're going to